Hello, I'm Don Lloyd-Jones, President of the American Heart Association, and I am so excited to join you to talk about a preview of the upcoming late-breaking science that you're going to see at this year's AHA Scientific Sessions, November 13 through 15, 2021. I'm joined today by Dr. Amit Khera and Dr. Manesh Patel. Dr. Patel, of course, is the chair of our Committee on Scientific Sessions program, and Dr. Khera is, of course, our able vice chair. Thank you so much for joining me. And we're also joined by Dr. Tracy Wang, who's a cardiologist at Duke University and is chair of the Council Operations Committee for AHA as well. Thanks all for being here today. And Manesh and Amit, why don't you tell us a little bit about this year's scientific sessions and some of the late-breaking science sessions?
Yeah, thanks, Don. Maybe I'll start and have Amit sort of go through. You know, one of the things that's always a highlight at our scientific sessions is late-breaking science. And again, even in this, unfortunate pandemic year, we've had 134 submissions for late-breaking science that we were able, with a large group of people, pare down to 7 late-breaking science sessions that are broadly across all of cardiovascular medicine. And maybe I'll go through a few of the themes and then hand them over to Amit to talk about them. We start with LBS1, which is cardiovascular surgical studies. You know, we actually have themes across 4 randomized trials where cardiothoracic surgery is being evaluated with different types of interventions, which we think is something that you might only see at the American Heart Association, and really importantly, broadening the kinds of care we can give for our patients. And that goes into, Amit, maybe you can tell us a little bit about some of the hypertension and prevention ones that we have in our sessions, because I know that's a passion for you.
Certainly couldn't be sessions without some prevention sessions, but there's a really innovative trial we'll talk about in a bit, and we also have it bookended by some other real-world evidence of how to treat hypertension. Certainly, what we're so excited about, you mentioned, Manesh, was this large bucket of trials that we received and how to pare them down into themes that would really be engaging for the audience. So hypertension really front and center. And then Manesh, I'm going to come back to you. We have a lot of sort of technology and electrophysiology and some new treatments.
Yeah, we have a couple of sessions we've sort of titled Information Overload to Prevention and Treatment of Atrial Arrhythmias. You know, there's so many ways in which, and we'll go through some of these studies, which we might detect arrhythmias, ways we might personally induce arrhythmias, ways we might prevent arrhythmias. And so those are all really kind of interesting sessions that I think a lot of people are going to care about. And I think that's another example of going from, CT surgery to hypertension to arrhythmia science. How about heart failure, Amit? Any big sections we have on heart failure?
Well, we certainly do. We have some, there's novel therapeutics we'll talk about in just a bit, but we certainly could not leave out heart failure, such a scourge in our population, and learning how to apply new therapies and what we're seeing both from patient outcomes, heart outcomes, and patient reported outcomes. I think we should just jump in, Manesh. Maybe you can tell us about some of the CT surgery trials, some of the key ones that we're going to hear about. And I will also say it's not common to have this big bucket of cardiovascular surgery trials. So we're really excited about what we think are really practice-changing studies.
Yeah, well, maybe I'll just take a second to go over 2 of them and then see what Tracy and Don think about them to get sort of their opinions of some of these areas. So maybe the first one I'll just talk about is a trial called Avatar, which is a randomized trial taking patients that have severe aortic stenosis and are not symptomatic. And these patients were randomized into watchful waiting versus early surgery. And they looked at clinical events in these patients, including cardiovascular death. So we'll be interested to see how potentially getting to our patients with severe AS that are asymptomatic, how asymptomatic was defined, and see if they do better. And the second surgical study I wanted to highlight is something led by our CT Surgical Network. A large group of NIH-funded investigators studied at the time of mitral valve surgery. A lot of patients going through mitral valve surgery have some tricuspid disease. Should the surgeon take some time to repair the tricuspid valve, and does that lead to better outcomes or not? So really 2 very, we think, practice-changing types of clinical trials that will certainly affect our practice depending on whatever the results are. Tracy, what are your thoughts about those types of trials? I know you know how hard it is to sometimes conduct some of these types of studies.
Yeah, these surgical trials, they're really hard to recruit into. So really kudos to the investigators for being able to pull something like this together. Very exciting. We're hoping to see something that really informs how we practice here. I'm especially looking forward to that asymptomatic aortic stenosis one. So lots to look forward to on the surgical front. And, if I may, I might extrapolate that a little bit to some of the cool things that we might be doing on the EP side of things. What do you think? One is the the trial looking at the Lariat procedure. So this is the AMAZE trial. And the Lariat is a percutaneous epicardial approach to ligating the left atrial appendage. This is something that our surgical colleagues will sometimes do as part of any sort of intracardiac type of interventions that they're doing. But now we're thinking about this in a percutaneous fashion, really in the hopes of trying to reduce symptom burden. So we'll be comparing that to PVI alone for patients with atrial fibrillation. So there should be some great insights there as well. And then, we're thinking a lot about, or a lot of folks are starting to use fitness devices. And so it's good to see the EP world also picking up on that and thinking about how we are managing the data streams that are coming from these devices. So this is there's going to be a very nice trial that's really looking at many of these consumer devices, such as Fitbit trackers or smartwatches, and looking to see how many of these really pan out to clinically significant arrhythmias, in particular atrial fibrillation. And so if we take these two studies and put them side by side, I think you'll really see, some are really more on the detection side, some are more on the management side, and we'll see a lot of the data starting to flow through to fill the gap in between.
Yeah, thanks, Tracy. Don, what are your thoughts about some of so certainly we're going to learn a lot about, Fitbit and devices to detect, and then potentially my EP colleagues may be doing things to try to help with the appendage, and we'll have to figure out if that actually reduces burden and reduces events. So that's going to be important. Danya, what about some of the hypertension research that you see coming? I know you've been thinking about this, and that session that Amit sort of hinted at has sort of a spectrum of things. What are your thoughts about that?
Yeah, thanks, Manesh. I think Amit gave us a nice preview. This is a session that's going to contain a really important real-world trial of doctors in villages in China trying to manage hypertension. I'm really looking forward to these results because our Chinese colleagues have actually done some of the best research into hypertension management, the best clinical trials we've seen in recent years. I'm thinking of the salt substitute study done in Chinese villages. Also thinking of the recent STEP study that showed us that, once again, like Sprint, targeting less than 130 was better than targeting a higher blood pressure control rate. Now we're going to see real-world management strategies by real-world docs in Chinese villages compared to kind of a control situation. And I'm really eager to see kind of what that management strategy looks like. But Amit, we're also seeing actually sort of management strategies that aren't using physicians, right, in large US-based clinical practices, and how we can do better at managing cholesterol and blood pressure. And also some other things, the impact of the COVID pandemic on blood pressure control rates in this country. What do you see in those two studies?
Well, you're spot on. It's beyond just hypertension is prevalent. It's what do we do about it? And we have the Chinese study, very innovative. We have another one in sort of a real world medical practice about using navigators and an electronic health based platform. So really seeing how we manage hypertension actively in multiple different areas, and sort of a window for others to do the same. So I think we're going to learn a lot about hypertension management in a really dynamic session. I want to stick with this theme of cardiometabolic disease, and heart failure and cardiometabolic disease are coming together, particularly with therapeutics. So we have a couple of heart failure studies we talked about, particularly focusing on SGLT2 inhibitors. Tell us a little bit about, Don, the MPulse trial.
Yeah, so MPulse, I think, is again pushing the boundaries. When should we start these SGLT2 inhibitors? We've had a little bit of data about starting in the hospital, but this is really, I think, the first large-scale trial that really tries to drill down on, can you take a hospitalized patient with heart failure, start the SGLT2 inhibitor immediately, and see if the outcomes improve? So I'm looking forward to that one. Tracy, were there other heart failure trials that caught your eye?
Yeah, I think along that same theme of SGLT2s, there's the Chief Heart Failure Study. This is one that's going to be really interesting because it is a trial that actually involves a lot of HFpEF patients. We've had a lot of trial data so far in HFrEF, so this will be something new. Also, there are a lot of patient-reported outcomes that's going to be shown here as well, so very exciting.
Yeah, I think that's great, Tracy, because I think it does take our patients and take their events and link them to those sort of high burden of symptoms in those heart failure patients. Well, this has been great. Maybe I'll just end with sort of saying what's coming in the future. And as for our last LBS sort of thinks about, we sort of thought about new drugs, new indications, some old drugs that might have new reasons that we might use them, and some new drugs for new indications. And in that vein, really that the last session sort of has 3 or 4 big themes. There's antiplatelet studies with aspirin in the ASCEND trial, which with the United States Preventive Task Force and some of the data we've seen from ASCEND, the AHA a few years ago was sort of telling people we don't need aspirin for primary prevention, maybe the way we were thinking about it, but certainly for secondary prevention, please talk to your doctor. We still want you on aspirin. ASCEND does talk about what about cognitive dysfunction and how does that look? So we're going to be interested in that. There's also a reversal agent for ticagrelor that'll be presented. And finally, we have some data on some factor 11 inhibitors, some new therapeutics coming. So pretty exciting set of LBS overall.
And don't forget a new oral PCSK9 inhibitor, Manesh. Something I'm really looking forward to checking out as well.
Data on an oral PCSK9 inhibitor. And we're going to have this sort of question. Would you want an injection or will you take a pill? And hopefully both of these things work so our patients have access. So once again, we're excited for everyone to be joining us for the scientific sessions. Great set of late-breaking science that we have over several days and 7 sessions. I want to thank my colleagues here who joined us today to go over these sessions. And thanks again. We look forward to you all logging in and interacting with us as we go through those.
We'll see you there.
See you there virtually.
Thank you.